Hi everyone, and welcome to our weekly podcast brought to you by VJOncology. This episode marks Bladder Cancer Awareness Month by covering the latest developments in bladder cancer. To begin, we have Joaquim Bellmunt from Dana-Farber Cancer Institute in Boston discusses the use of circulating tumor DNA to monitor minimal residual disease in patients with muscle-invasive bladder cancer.
Nowadays, we are using the ctDNA to monitor. It's a way to monitor minimal residual disease. So, as mentioned, in this situation, it's pretty clear in the perioperative space, right? So after surgery, everything has been resected. Patients may have or may not have high-risk factors. And the question is, what need to be given? Nowadays, if it's more than T2, more than T3, you can give nivolumab or pembrolizumab. What to do in patients with T2? What we're doing nowadays is check the ctDNA, and if the ctDNA is positive, then you can start giving immunotherapy. And also, the ctDNA is being implemented with the idea of bladder preservation. So, with the new explosion of results in the perioperative space, we saw here at ASCO GU the results of the EV304 using EVP, neoadjuvant surgery, and adjuvant EVP. What's happening is that patients that are receiving 4 cycles of EVP before surgery, the rate of pathologic complete responses, so no tumor left behind, is really high. It's 65%. So it's amazingly high. And the question here is, in these patients that obtain the complete pathological response, do we need to give adjuvant therapy? And here's when people start implementing the ctDNA, say, well, maybe if a patient has a complete pathological response and the ctDNA is negative, maybe we can save them to give additional adjuvant therapy. But nowadays, we cannot do that. So those are assumptions. Maybe patients that are having toxicity and able to receive adjuvant, in these patients, you could hold the treatment. But nowadays, what needs to be done is give neoadjuvant, surgery, and then adjuvant. And obviously, people is thinking that based on this high rate of pathologic complete response, we are thinking on bladder preservation. So if you receive 4 cycles of EVP, you see that the ctDNA goes completely negative. Imaging like a 3T-RVT, everything is gone. Maybe these patients being monitored with ctDNA, we can preserve their bladder. So that's the future. If we need to add radiation therapy or not, that's the question. There are clinical trials nowadays that this is the aim, giving this the strongest combination in the neoadjuvant setting that leads to this high rate of pathologic complete responses, and then try to preserve the bladder. Even giving additional treatment, given radiation therapy, but I think that's the future. Still, we need more data because, as mentioned, in the IMvigor011, we saw that patients that, when checking the ctDNA being negative, the patients didn't recur, but at 1 year, there is 12% of patients that still can recur, having the ctDNA being negative. So it's still there need to be an optimization of this test in order to capture the minimal residual disease. And in fact, Signatera, there is a platform that is, Signatera has two ways of interpret the positive or negative. So positive is if you have 2 or more variants detected in the blood, the test is positive. But then there is this other way that is looking for the concentration based on the levels of MTM per milliliter. So MTM stands for mean tumor molecules per milliliter. And that way, maybe we can score how much tumor is floating around. So this platform that is based on 16 genes, now this is being expanded. So life is going to be much more sensitive and much more specific. So yeah, the future is brilliant because we are improving in this sense of capturing the minimal residual disease.
Next up, we have Compérat from the Medical University of Vienna, who highlights the challenges in detecting and diagnosing urinary tract diseases and your approaches in intravesical therapies.
So what I try to say, first of all, there are very many new approaches in intravesical therapies. I mean, we have at least 6 or 7 new BCG plus treatments. We have very many other treatments. Some are a little bit known, others are less known. For example, HIVEC is pretty well known now. There's TAR-200, TAR-210. There are very new approaches with interleukin 15. I think this is very, very promising, the N803. So I think really things are going on. Then we have, of course, to do a kind of evaluation because the follow-ups of these new trials are very short. So at the very moment, we do not know very well whether this is as good as BCG or not. But I'm pretty convinced that some new treatments will really remain. Maybe not everything, but some of them will for sure remain. For us as a pathologist, having the biopsies is not always evident because we have very, very small biopsies, and then we have to do not only the diagnosis, but also the testing about Lynch syndrome and other things. So it's not easy at all. So I think this is, for at least for us in pathology, the most challenging thing.
Following on, Roberto Contieri from Humanitas University comments on the potential benefits of a de-escalated treatment strategy as an alternative to the classic approach for patients with low-grade, non-muscle-invasive bladder cancer.
We know that low-grade TA tumor have a very low risk of progression and a negligible cancer-specific survival. Also, treating bladder cancer is expensive, and this is partly due to the overuse of surveillance in these precise patients. Also, we know that the standard treatment for these patients is transurethral resection, but transurethral resection is not a free complication procedure with a 5% complication rate at 30 days. And also, we know that when we find a recurrence, urologists are enough accurate to identify low-grade recurrence only with cystoscopy. So that's for all this reason, there are some patients who may benefit to intensify treatment. These patients will progress probably, will not die for this cancer. So what we can offer them is identify strategy as an alternative to classic TURBT. For example, office fulguration and laser ablation, active surveillance, and chemoablation. Of course, that we usually, the best patients for those approach are patients with a story of low-grade tumor. So we know we have a pathological report saying that the patients had a low-grade tumor and then a small recurrence. Of course, guidelines are not very precise in identifying the best patients. For example, for office fulguration, they say small tumor, don't identifying a cutoff. Usually, it is 1 centimeter lesion. But for example, there are also trial using a higher cutoff, like 2 or 3 centimeters. For active surveillance, there are some prospective studies, such as the Bladder Italian Active Surveillance Protocol, which enrolled patients with recurrent tumor smaller than 1 centimeter and with at most 5 lesions. Of course, these are not randomized clinical trials, just a protocol with inclusion criteria decided by experts, and we don't have enough evidence to say that these patients are the best for active surveillance. But what we can do is to use this data to build a consensus, and that's what we have done recently. We published a Delphi consensus on active surveillance involving more than 50 experts in bladder cancer who expressed their thoughts about inclusion and exclusion criteria. For example, patients with positive cytology should not undergo active surveillance for sure, and also patients with big tumor. But I think what is very interesting right now in this setting is chemoablation, because we know that there are several agents that can eradicate visible tumor. For example, mitomycin. We have a DABLA-CAT13 study, which is a randomized clinical trial showing that patients undergoing intense schedule with mitomycin administered 3 times a week for 2 weeks achieved a complete response rate of 57%. However, to further intensify the strategy, we have also novel delivery systems, such as, for example, a reverse thermal hydrogel combination, UGEN-102, which was approved last year by FDA for recurrent tumor. But also there are the TAR-210, and last year at AUA, there was a phase 1 study showing a complete response rate of 90%. So I think that the intensification is not theoretical, it's practical, it's already present in the guidelines, and we can apply it every day, but we need to pay attention to the selection of the patients. And this is the most important thing. We are also collecting data through an European registry supported by the YAO group, Urothelial Cancer Carcinoma group. And so we are collecting this data of prospectively of patients undergoing this de-intensified approach to support this approach and provide additional evidence.
Finally, we have Vadim Koshkin from the University of California, San Francisco, provides an overview of the molecular landscape of tumors and their classification of bladder cancer into subtypes, including luminal and basal subtypes.
Urothelial cancer is, quite a diverse disease, and we encounter actually in clinic, not infrequently, quite a few different variant histologies. Most of the time, these are variant histologies that arise in the background of urothelial carcinoma. And so these are entities like, for instance, a squamous or sarcomatoid or plasmacytoid. And, generally, again, they're present as a minority component with majority component urothelial. Sometimes, though, we do see a more extensive variant component as well. Separate from that, we also see basically non-urothelial cancers that arise in the bladder as well. And that could be entities like pure squamous cell carcinoma, sometimes pure neuroendocrine carcinoma, adenocarcinoma. Those are actually quite different. And we probably, from a therapy standpoint, approach them quite differently than the first category I went over. The first category, so again, variant histologies that arise on the background of urothelial cancer, these are, they certainly make us pay attention. I think, this is something where, when you see a patient like that in clinic, you zero in on this and you really think about, well, should I somehow approach this patient differently, than I would a patient with, pure urothelial histology. There are now, some trials to look at this question. Actually, Andrea Paolo at the NCI is running important studies there. There are other investigator-initiated trials as well. But I think we have some at least initial retrospective data from the UNITE study, the UNITE registry, where we looked at this question of whether, the sort of newer potent systemic therapy that we use a lot now for patients with urothelial and bladder cancer, namely EV and pembrolizumab, whether that works, as well for these patients with variant histologies. And at least in the metastatic setting, again, what we're seeing is that EV and pembrolizumab does have activity for these patients. So this is a retrospective analysis in a nice study that we did initially with looking at just informative vedotin monotherapy. And we published this data earlier this year in European Urology. Now we have a study looking at the same outcomes in the same patients, but with the EV and pembrolizumab combination. And that is data we presented as a poster at ESMO just this past year. But what we're seeing is that actually informative vedotin and pembrolizumab do have activity in patients with variant histology, though this activity does decrease as the extent of variant histology increases. So it's highest for patients who have mostly urothelial histology with a component of variant. If they have majority variant with a component of urothelial, then the response rates are lower, but they're still there. For pure variant histology, we see some responses with EV pembro, but they're much fewer for sure. Now, it is encouraging that we do see some responses, and that's why I, often for these patients, this is certainly a regimen that I would consider. A histology where perhaps we should be more cautious with this approach are neuroendocrine or small cell bladder cancer patients. And because presence of that histology really unfortunately portends pretty poor outcomes. And I'm not as convinced that informative vedotin-based regimens kind of work all that well there. As part of this question, you also asked about molecular subtyping. And that's an altogether kind of very different question. That's looking really at the molecular landscape and really the expression landscape in tumors and trying to basically classify them into groups, right? And these groups, can correlate somewhat with the presence of variant histology, but it's an imperfect correlation at best. Generally speaking, when we split patients into these molecular subtypes, there are luminal versus basal subtypes. This is, classification that initially comes from breast cancer, but it's been at least somewhat adopted in bladder cancer as well. But there, as a broader pattern of classification, there are now even different subtypes within luminal, within basal. There's also a separate neuroendocrine subtype. What we see is that, again, with luminal subtypes, there is more probably Nectin-4 expression. There's more of some of the other relevant alterations like FGFR3 alterations. Also probably HER2 expression potentially is higher there. So, and most of our currently available therapies, certainly targeted therapies, would probably be directed at those subsets. Patients with a basal subtype are certainly in need of additional treatments and additional options. This is, again, just maybe a more general overview of this. I would say in clinic right now, we don't really use this to make decisions, But I think this is, subtyping these tumors is, potentially an important future approach that we should really kind of prospectively investigate in clinical trials to see if there is a reliable way to identify patients who, again, based on molecular subtyping, who can respond to certain therapies versus those who won't, and where we should, consider other options.
Thank you to our speakers and to you for listening to this podcast. If you enjoyed this podcast, please leave a review and subscribe on your favorite podcast app, including Apple, Podbean, and Spotify, so we can continue to deliver our expert-led content directly to you. Follow us on X at VJOncology and join in the conversation, and visit VJOncology.com for the latest updates in the field.